The national success rates in IVF vary between around 45-50%, whereas we in Nova, we have success rates around 60-70%.
How do the success rates vary with age groups?
So we all know that the more advanced is the age, the success rates will go down.
How many cycles are needed to get a good success rate?
We may need to do 2 to 3 cycles so that we get good blastocysts. So we may have to go for more cycles, more than one. What is the role of PGTA and is it going to improve my success rate? What do you think about that?
It is like that when we have an apple tree or any kind of fruit tree, all these fruits are not of the same size and not of the same genetic make. So to differentiate between them, which is normal and which is abnormal, that's where the PGTA comes into the action. Hi, I'm Dr. Waseem Andrab. I am Cluster Head Embryology from Nova-Southend IVF Fertility, and I am based in Delhi. And with me today is Dr. Sandeep Talwar, ma'am. Welcome, ma'am. We will be discussing some important questions when patients come to our clinic to discuss with us about the success rates. Ma'am, please.
Good morning. I'm Dr. Sandeep Talwar, a Senior Consultant Nova IVF Fertility Delhi. And today we are going to talk about some common questions. Dr. Waseem, what do you think is the commonest question which the patients have when they come to us?
So whenever a patient comes, whether they want to meet any clinician or whether they want to discuss with embryologist, the first question which is the most important question they ask is about the success rates. So they ask us that what is the overall success rates, whether it is national or your Nova Fertility Center?
That is the benchmark of any IVF center. And the national success rates in IVF vary between around 45-50%, whereas we in Nova, we have success rates around 60-70%. These are the Nova success rates.
So this is the first question. The second question is that, which is also very important regarding success rates, is that how do the success rates vary with age groups? Because most of our patients, they are usually of advanced maternal age group. So I would like your thoughts on that. How does it vary with the age groups?
So we all know that the more advanced is the age, the success rates will go down. So let's talk about people who are more than 35 years of age. The most commonly affected thing is the oocyte quality. And as well as the ovarian reserve or the capacity of a woman to make eggs goes down. And there are more incidences of having abnormal chromosomal makeup or in the embryos. So these are the things which happen in the women above 35. If we are talking of less than 35, then again ovarian reserve has to be checked. Then there could be coexisting male factors. So there could be a male infertility also. So these are the things which have to be seen in these.
Also, we just want to tell you that male infertility is on a major risk here. So previously it was being thought that women are only responsible for infertility, but nowadays when any couple is coming to our center, we have found that most of the males, even with the normal semen parameters, they have abnormal morphology. So somehow that also, because whether you are living in the metro states, how good your health is, these all things come into the existence. And that's a valid point that it is not just from the woman. So men also plays an important role. They equally contribute, whether it is genetically or whether it is emotionally. So then we will move on to the other rate. The important question about is that, well, when couples come to our visit, they ask about what is a clinical pregnancy rate and what is a live birth rate.
So this is clinical pregnancy rate says when your beta HCG value, this is the hormone to test pregnancy, this is positive. As well as we see a gestational sac inside the uterus. So if these two things are there, then we say it is a clinical pregnancy rate or it's a clinical pregnancy. And if we distinguish it from the live birth, as the word is self-explanatory, that means to have a live baby. It could be preterm, it could be at term. So that live birth and the clinical pregnancy rate could differ. because people could have abortions in between also. So those rates could be different between the two things. So that's how you measure success as the live birth rate.
So it is, in short, we can say it is not just a clinical pregnancy rate. The most important thing in an IVF center is the live birth rate. That's why we should more go into, because clinical pregnancy rate, anyone can have a positive beta HCG, but how good this pregnancy moves on, and you can have a proper healthy baby, a live healthy baby. That's most important thing that a couple always intends to see a child in their arms.
So then I would like your thoughts, Dr. Waseem, whether what would you prefer? Fresh embryo transfer, you would say, are better, or frozen embryo transfers are better, and why do you say so?
So there are two school of thoughts. One is fresh. Usually we used to do it before, and I am now, because most of the people are shifting towards the frozen embryo transfer. One particular reason I would say for moving up this towards this trend of moving to frozen embryo transfer is the strong vitrification protocol. If we see before, we were using this system, which is then what we call it as slow freezing. So in slow freezing, the survival chances were very less. And when we talk about vitrification, which is a rapid freezing, we almost get about more than 90% survival rate. That is one of the reasons that people are moving towards the frozen embryo transfer. But when we talk about the success rate in fresh or frozen, then there are certain categories of patients. There are patients who have less ovarian reserve. That means we are expecting less number of eggs. So they will get stimulations accordingly. It's not necessary that we need to give them high doses. So a mild stimulation, and then getting those 2 or 3 or 4 follicles or eggs, and then forming an embryo and transferring in the fresh cycle, although it varies also with their hormonal levels as well. But ultimately, if you see initial-wise, the fresh embryo transfer was the success rates were between 40% or roughly around that. But since we have moved towards these frozen embryo transfer, also we have to take into consideration whether there is any risk of OHSS, then it can also be problematic. It is also very important that when we talk about fresh and frozen embryo transfer, that individualization is very important. We have couples who have less number of embryos, less number of eggs produced, that in those cases, we will always try to go with the fresh embryo transfer. However, when we are getting more number of embryos and there is a risk of OHSS, then we prefer always the frozen embryo transfer. And it has been seen that frozen embryo transfer has slight advantages in terms of success rates when compared to the fresh. So if we talk about the fresh embryo transfer, as I said, roughly around 40%, then you may go, this frozen embryo transfer may have another 10 to 20% advantages. So there is one more question which always comes to the mind of the couples who come to visit our center, is that how many cycles are needed to get a good success rate?
So that will also depend on the individual case-to-case basis. You can't say one size fits all, because there could be a patient who has a good ovarian reserve, the male factors are all normal, maybe it's something just PCO or a tubal block, where we will get very nice good embryos. So we get good blastocysts. There we don't need more than one cycle. Maybe if we have done a lot of good quality blastocysts that we have frozen. But there are these people who are advanced maternal age or poor ovarian reserve. In those cases, we may need to do embryo pooling. We may need to do 2 to 3 cycles so that we get good, say 3-4 good blastocysts. So we may have to go for more cycles, more than one. So it would also be very individualized depending on the patient profile and the ovarian reserve and the male factor which is there.
So basically, every cycle rate or every cycle success rate depends upon the couple who is coming to visit us. So it's nothing like that you will get success in a one go or you will not get success in a one go. So it's always your eggs, your sperm, how good quality of embryos we will get. Even a patient that just having 2 embryos and they are of good quality, they can give us a good live birth rate. While a patient having different kinds of embryos, different number of embryos, 10 embryos, and it can still result in a negative.
Yes.
So that's when we talk about something which we call it as the genetic testing.
So, this is a very, very common question that, Dr. Waseem, that we get a lot of patients who have failed from other centers and who come to us. And one very commonly asked question from them is that what is the role of PGTA, and is it going to improve my success rates, and how is it going to happen? So what do you think about that?
So it's also very important that patients should know what they are doing and what we are doing for them to increase the success rate. And definitely PGTA is something which can add to the success rate. So if we talk about PGTA, which is called as pre-genetical testing for aneuploidy, so it is basically to check the chromosomal content of an embryo. Usually we do this embryo biopsy on day 5 embryos, that is the blastocyst embryos. Then we check how good the embryo is and how good genetically it is. So if it comes out to be genetically normal, the chances of success rate is much higher than those who are abnormal. It is like that when we have an apple tree or any kind of fruit tree, all these fruits are not of the same size and not of the same genetic makeup. So similarly, when we are doing anything in the lab, so not all the embryos are euploid, or we say that they are chromosomally normal. So to differentiate between them, which is normal and which is abnormal, that's where the PGTA comes into the action. And this also helps in reducing the pregnancy time, because rather than going a failure if we are transferring an abnormal embryos, or rather than resulting in a miscarriage if we are transferring an abnormal embryo, the chances of success rate always improves by another 10 to 20% if we are doing the PGTA.
Yes, so it's very important that you are reducing time to pregnancy.
Yes,
that's what we are doing, and we are not doing the thing blindly. We are going knowingly, knowing that these are euploid embryos.
Yes, that's very correct, because Nova is mostly known for its ethical work. So everything we want to get transparency about all the things what we are doing, and patients should also kind of know what we are doing for them so that they understand the science and doing nothing but science.
Yes.
So this concludes our top 5-6 questions, and we will come back in next episode with more questions. We'll see you in the next episode. Thank you.
Thank you.